Hello, I'm Dr. Diana Chavkin here at SCRC Fertility. Happy Friday, everybody. Thank you for tuning in. I'm going to talk about the process and the background and reasoning for egg freezing. But please feel free to ask questions. More than happy to make this interactive and really answer whatever is on your mind to the degree that I can in this period of time. So just to talk about the background of egg freezing. So the idea is that women are born with all of the eggs that they will ever have. Unlike men who produce sperm throughout their lives, women are born with a finite number of eggs. And as women get older, they not only lose eggs in number, but they lose eggs in quality. And as women have less eggs in their ovaries and less egg quality, they're less likely to get pregnant. Eggs are less likely to fertilize, result in a pregnancy, and less likely to result in a normal pregnancy. And when I talk about eggs being less good quality as a woman ages, what I'm really referring to are the chromosomes in the egg. So as a woman ages, the chromosomes essentially become unstable and are less likely to result ultimately in an embryo that has a normal number of chromosomes. And if the embryo doesn't have a normal number of chromosomes, then it's unlikely to result in a pregnancy. And again, even if it does, it's more likely to result in a miscarriage or even worse, have a woman be pregnant with something that's chromosomally abnormal, which then potentially may need to be terminated or dealt with. And so, women are at any point in time in their lives, the youngest they'll ever be compared to any point in time in the future. And so what that means is that at this point in time, a given woman has the most eggs and the best quality eggs compared to any point in time in the future. And so if a woman knows that she is potentially interested in having a child in the future but is not ready now, I often recommend that they do something like an egg freezing cycle. Now, if a woman has a partner that she knows 100% this is who she's going to have a child with, then I say create embryos, because embryos we can actually test and see if they're chromosomally normal. Eggs we can freeze and fertilize later and test to see if they're normal later on. So it's a little bit less information if we freeze eggs. Embryos gives us more information. So that's often what I say if a woman has a partner. But if she doesn't, then no pressure to create embryos. Really, egg freezing is an absolutely wonderful thing to do, because by freezing a given number of eggs at a point in time, that increases the chance that a woman will be able to conceive down the road. Because once those eggs are frozen, they're not going to degenerate in quantity or quality over time, so that when she freezes those eggs, she essentially locks in the chance that she'll be able to conceive based on the age that she froze it, not the age at which she uses it. So a woman can freeze a certain eggs, let's say in her 30s, use her eggs in her 40s, and her chance of being able to have a normal embryo is dependent on the age in which she froze them. So much more likely to have a normal embryo if she freezes her eggs in her 30s than if she were to freeze eggs in her later years. And so the way that this process, so that's essentially the reasoning for egg freezing. And so the way that this process would work is we usually will have a woman do essentially a workup. So she'll get infectious disease testing, hormonal tests. We'll always want to check a thyroid, a vitamin D, just make sure she's overall healthy. We'll want to do a follicle count. So I'll usually tell my patients, come in for your baseline ultrasound for your follicle count to get an idea of your ovarian reserve. There are essentially two portions of the ovarian reserve testing. There's an AMH level, which is a hormone level that assesses ovarian reserve. And then there's a follicle count that's done at the beginning of the menstrual cycle. A follicle count counts up the number of follicles. So the follicles are pockets of fluid that have microscopic eggs. The more follicles a woman has at any given point in time, the greater her ovarian reserve is. So we can do that follicle count, get an idea of the ovarian reserve, get the AMH, get an idea of the ovarian reserve. And I actually never use those numbers to tell a woman if she is a candidate for egg freezing or not. So any woman who's ovulating, essentially not menopausal, and potentially interested in having a child in the future but not ready now, that in my opinion is a candidate for egg freezing. Now the AMH and the follicle count helps to hone in and give us an idea of prognosis, potentially how many eggs to expect, how many cycles maybe a woman might have to do or might want to think about doing. And I actually use that information primarily to give me an idea of what starting dose of medication to put a woman on so that I get as many eggs as I can in a given treatment cycle. So in any case, so we do that workup, and then once that workup is completed, we'll have a woman reach out with her period, and then sometimes we'll put her on birth control pills prior to the stimulation. Sometimes we'll start the injections without the birth control pills. One of the benefits of the birth control pills is that it helps to regulate the cycle, and that it helps to create a situation where the follicles and the hormones are all symmetric. So what happens in the normal ovulatory cycle is that the brain is constantly secreting gonadotropins to stimulate the follicles, to stimulate the eggs. What happens in a normal ovulatory cycle is that one egg, one follicle becomes dominant. What happens to all of the other follicles and the eggs that are there is that essentially they die off. So every month the brain is secreting a certain amounts of gonadotropins, help to stimulate follicles and help to nurture, so that one egg, one follicle becomes dominant, the rest die out. What do we do in an egg freezing cycle? So we essentially want to rescue and save all of those follicles, all of those eggs that would have died that month. And so we will have a woman inject herself with gonadotropins, with hormones, again, the very same hormones that your brain ordinarily produces, but at much higher doses, because we don't want just one or two follicles to get recruited and stimulated. We want all those follicles that would have died that month to grow and stimulate. The issue sometimes is that if the brain is secreting hormones and then I'm having a woman take injections and take hormones to stimulate the ovary, a lot of times the ovary gets mixed messages. It gets one message from the brain, one message from the gonadotropins that I'm having her inject with, and then sometimes what that results in is a stimulation process where we have an uneven number of follicles, meaning some follicles are big, some follicles are small. And so then when we get to the egg retrieval process, we don't get as many mature eggs as we ordinarily potentially would have gotten. And so by putting somebody on birth control pills, what that does is it tells the brain to stop secreting gonadotropins. So the brain's hormones are no longer in the equation, and then I can have a woman take injections and essentially stimulate the follicles in a more symmetric way. So that's the main purpose of the birth control pills. And usually birth control pills are maybe, 10 days, 2 weeks, 3 weeks. We try not to do it for too long. We try to do it for enough time so that we get the adequate suppression. Again, we get the brain's hormones out of the equation. So then the heart of the process is essentially after a woman has taken birth control pills, usually on the 5th pill-free day, or again, if she hasn't taken birth control pills, we'll have her come in on day 2, 3 of her period, and then we'll get hormones, ultrasound to confirm that she can start the process. The process is essentially where she'll take subcutaneous injections, so thin, small needles. A woman will self-administer. We teach patients how to take the injections. They take the injections for a period of about 10 to 12 days. While they're taking those injections, they'll come in to see us for blood work, ultrasound, monitoring visits, where we essentially are assessing the response to the medications. Are they responding? Do they need a higher dose? Are they responding too fast? What are the follicles that are growing? How are they growing? And we use that information to tweak the situation. So do we increase the dose, decrease the dose, when to come back? And then we'll get the woman to the point of the egg retrieval procedure. That's usually about 12 days after the beginning of the injection. So it's usually 10 days of injection, usually on the 10th day, give or take a few days. Usually on the 10th day, she'll take her final injection, her trigger shot. And then 35 to 36 hours later, the egg retrieval will occur. The egg retrieval is done under anesthesia, so a woman is completely asleep. We place an ultrasound probe in the vagina attached to a needle. We'll take fluid out of the follicles. The fluid will have the eggs in them. The embryologist is sitting right there looking at the fluid, taking the eggs. They'll freeze the eggs, and there they stay frozen until you need them. And so, let's say a few years later, you're ready to have a baby, and potentially now you're a few years later, so it might be harder. Again, less eggs, less good quality eggs, and so you may say, okay, time to do IVF. To be able to fall back on eggs that were frozen at an earlier point in your life, you're going to be much more likely to have embryos and much more likely to have normal embryos created in that situation. And so let's say you say, okay, time to thaw the eggs. So what would happen is we thaw the eggs, fertilize the eggs, make the embryos. The embryos grow out for about a week. We then biopsy the embryos, freeze them at that point, find out 2 weeks later if they're normal, and then if they're normal, we do an embryo transfer. The chance of pregnancy, of normal healthy pregnancy with a chromosomally normal embryo is about 70%. That's all potentially later. The heart of the egg freezing process is about 12 days from injections to retrieval. Usually most women feel fine when they're taking the injections. The most common thing people experience is a bit of bloating, not much else. There is a risk of something called ovarian hyperstimulation syndrome. That's a concern where there is essentially overstimulation, causes issues of fluid imbalances, potential risk of blood clots. Very low risk of that happening, but that is a potential risk and something we look out for. There's also a risk of something called ovarian torsion, where the ovary can twist and cut off its blood supply, so you need to be careful about exercise. No running, no jumping, no yoga, no twisting, nothing that would cause that ovary to twist. The only day that people are really out of commission is the day of the egg retrieval, and mostly that's because of anesthesia. Most people are good to go back to work the next day, so this really shouldn't be a very time-consuming effort, and that it really shouldn't take too much time away from your friends, your life, your work. It's meant to be a discrete period of time, one day of the egg retrieval, you're kind of out of commission. Okay, and so I think that's maybe enough information to convey, and I'm happy to open this up to questions. So somebody is asking me, is a hysteroscopy with DNC beneficial prior to conceiving? Does that increase the chances? So, it really depends on the specific situation. I think in general, we don't, say, if you've been having trouble conceiving, you should definitely get a hysteroscopy with a DNC. It's not really standard of care. Usually we recommend that you do a hysteroscopy and potentially with a DNC if there's a reason. So if, let's say on water ultrasound or on regular ultrasound, we see something in the uterine cavity like a polyp or a fibroid or tissue or something concerning, then we would do a hysteroscopy. A hysteroscopy, for those of you who don't know, is a surgical procedure where a woman is brought to the operating room, and the doctor will place a camera inside the uterine cavity, and then we can visualize the inside of the uterine cavity. If there's any tissue or scar tissue or polyps or whatever it is, that can be removed under direct visualization. A DNC is a sampling of the lining of the uterus, and that's sometimes recommended in specific situations, but not always. So should I do an IV drip? So I'm not sure exactly what that question is referring to. I think, in general, if you're going to do stimulation, you have to speak with your specific doctor who knows your particular history. So there are often medications that I say that women should be taking during their stimulation and their IVF process and even their embryo transfer process. But there's certain medications where we kind of say to hold off. Most medications are actually fine during the egg freezing process and even the stimulation for an IVF process to actually create embryos. It's when we're doing the transfer process and somebody's imminently going to be getting pregnant, then we're a little more strict about what medications they're taking. If somebody's on psychiatric medications like antidepressants, I definitely don't say, come off it if you're going to be doing a transfer. So I will usually have them speak with somebody called a reproductive psychiatrist who can go over with them the risks, benefits, and alternatives of being on that specific medication to make sure that they're aware of the risks and what we know and what we don't know about being pregnant, in early pregnancy on those medications. But again, for the egg freezing process, there's very few, if any, medications I tell people they can take during the egg freezing process, because even though we're developing the eggs and we're getting mature eggs, it's not like there's an embryo that's biologically active in any way that could essentially be affected by the medication. So even though we have certain medications that we say are teratogenic. Teratogenic means that if you're taking those medications when you're pregnant, it can cause serious harm to the developing fetus and the developing baby. And so for those medications, we have to be very careful during the embryo transfer process. But for the IVF, when somebody's taking medications for stimulation and doing an egg freezing process, most, not all of those medications are totally fine during the stimulation process. But that, again, has to be a conversation specifically with the doctor who knows you and who's taking care of you. So is hysteroscopy recommended for patients with endometriosis? So, hysteroscopy, again, so regardless of kind of what the diagnosis is, a hysteroscopy is essentially done if there's a suspicion that there is something in the uterine cavity that needs to be evaluated and needs to be treated. Endometriosis is a disease where the cells that usually just line the inside of the uterine cavity implant outside of the uterus. and potentially in the fallopian tubes, on the ovary, on the abdominal cavity, and it's thought that potentially that can cause scarring, pain, inflammation. One of the ways that endometriosis specifically is confirmed is by laparoscopy, but that's where a camera is placed actually into the abdomen, usually through the belly button, and taken a look, and there's biopsies or pictures that are taken to confirm what are usually primarily diagnosed first and foremost by symptoms. Hysteroscopy is not necessarily the way to treat or diagnose endometriosis. Okay, so somebody was diagnosed with endometriosis, and unfortunately a very common diagnosis. So endometriosis is, again, as I mentioned, if there's the cells that usually line the uterus and plant elsewhere, and it can cause significant pain and scarring. So the question is I'm not sure if IUI is an option or what's needed, IUI versus IVF. So again, there's a lot more information that needs to be known. I wouldn't say that just because you have a particular diagnosis that one, treatment course is better than another just based on that diagnosis. Different things need to be evaluated. So a semen analysis, an AMH, a follicle count, a hysterosalpingogram to evaluate whether the fallopian tubes are open, how many kids somebody wants, because even people who come to see me and they say, oh, I'm having trouble getting pregnant, I want to get pregnant, I always ask people, how many kids do you want? Because there's often a need for a conversation of, well, okay, if this one's hard, the next one and the next one may even be harder. So we need to think about IVF for embryo freezing potentially for a second and third kid, right? So we don't always want to just think about that first one. So the question as to whether IUI or IVF is needed, it's really hard to say just based on, again, on a diagnosis. There's a lot more that needs to be known in order to make that recommendation. Any other questions? I know we talked a lot about egg freezing, touched on hysteroscopies, endometriosis, but any other questions, you're free to send them over. Appreciate you guys checking in on a Friday afternoon, lunchtime. If any other questions come to mind, please feel free to reach out to schedule a consultation. Happy to speak with you in person or video chat, whatever works. And have a wonderful Friday and a beautiful weekend. Thank you.